Welcome back to the Deep Dive. Today, we're going to do something a little different.
Oh, yeah.
Yeah. Usually when we talk about the human body, you picture, biology class, cells, DNA, mitochondria.
The powerhouse of the cell, right?
Exactly. But today, I want you to just completely shift your perspective. Think about the body as, a piece of heavy industrial engineering.
I like that. A mechanical shift, moving away from the microscopic and into the mechanics of it all.
Precisely. We're looking at a complex, high-stakes plumbing system. We're talking pipes, pumps, flow rates, pressure valves, and specifically a closed-loop system where managing that pressure is, quite literally, the difference between life and death.
It really is.
If the pressure gets too high, the pipes burst. And if these specific pipes burst, well, the consequences are catastrophic.
It's a fitting analogy because when you really boil it down, vascular medicine is just fluid dynamics. It's physics. And today, we're talking about a condition where those pipes are under immense strain because there's a blockage in the body's most important filtration plant.
So we are diving deep into portal hypertension.
Portal hypertension.
It sounds intense. And to guide us through this, we're working with a really fascinating document today. It's not a pop science article or, some health blog.
No, not at all.
We're working off a clinical, exam-oriented masterclass.
Yeah.
It's designed for high-level medical students.
Right. This is stuff meant for people prepping for the USMLE, NEET PG, their final boards. I mean, these are the notes used to train the people who will be saving our lives one day.
So it's dense. It is packed with data, numbers, Latin terms. But our mission today is to decode all that.
To translate it.
Exactly. We want to take that high-yield medical data, which, let's be honest, can be incredibly dry on the page, and turn it into a clear, conceptual understanding of, liver pathology, vascular physics, and even emergency medicine.
And it applies to everyone, really. Whether you're a med student cramming for an exam or just someone who's super curious about how the machine works, this topic really highlights how interconnected the whole body is.
It does.
It integrates liver disease, GI bleeding, critical emergency management. It's a life or death mechanic. If you understand portal hypertension, you understand a huge piece of how the body handles trauma and disease.
Okay, so let's start at the very beginning then. What exactly is portal hypertension? Because when I hear hypertension, I immediately think of the blood pressure cuff at the doctor's office.
Of course.
The nurse pumps it up, it squeezes your arm, they give you a number, 120/80. Is that what we're talking about here?
And that's the most common misconception. It's so important we clear that up right away.
Okay.
When your doctor checks your blood pressure with that cuff, they're measuring systemic arterial pressure.
Systemic.
That's the pressure in the arteries carrying oxygenated blood from your heart out to your muscles, your brain, all the way to your toes. That's the high-pressure delivery system.
So that's like the main water main for the whole city.
That's a perfect analogy. Portal hypertension is completely different. It's high blood pressure, yes, but it's specifically localized within the portal venous system.
The portal venous system.
It's a completely separate circuit. It has its own rules, its own pressure gradients, and its own unique purpose.
Okay, let's unpack that.
Yeah.
Where is this system?
Yeah.
If I'm looking at a map of the body, where are we pointing?
We're pointing right at the abdomen. So think of the portal vein as this massive gathering point, like a funnel.
A funnel, okay.
And its job is really unique. Unlike other veins that just, carry used blood back to the heart, the portal vein collects nutrient-rich blood from your stomach, your intestines, your spleen, your pancreas.
So it's gathering all the stuff we just ate and digested.
Right. It's full of nutrients, but also toxins, medications, everything you've just absorbed. But instead of sending that blood straight back to the heart to get pumped around,
It takes a detour.
It funnels all of that blood into the liver first.
It's the intake pipe for the factory.
That is the perfect metaphor. The liver is the body's chemical processing plant. It has to filter toxins, process nutrients, metabolize drugs before that blood is allowed into the general circulation.
I see.
So the portal vein brings the raw materials in. And portal hypertension is what happens when the pressure inside that specific intake pipe gets way too high.
So sticking with our plumbing analogy, we got a traffic jam. The blood wants to get into the factory to be processed, but it just can't get in fast enough.
Precisely. And the reason this matters, the reason it's such a critical topic for exams and for survival, is that this one system integrates so many critical functions.
Right.
If the pressure spikes in this loop, you don't just, get a headache or feel a little dizzy. You get catastrophic structural failures in the veins. You get internal bleeding. You get organ failure. It's a systemic collapse caused by a very local blockage.
Okay, we've definitely set the stakes. We know it's dangerous. Now, since our source material is an exam masterclass, it's very specific about the numbers.
It has to be.
It seems like in medicine, you can't just say the pressure is pretty high. You need to know how high. So what are the magic numbers here?
In the clinical world, precision is everything. We measure this pressure in millimeters of mercury, or mmHg.
Okay.
Now, to give you some context, the normal pressure in the portal vein is incredibly low. We are talking about 5 to 10 mmHg.
5 to 10. Wait, that sounds tiny. If normal blood pressure is 120, 10 is like nothing.
It is nothing. It's supposed to be a gentle river. It's a low-pressure, high-volume system. It's meant to be lazy and steady. The blood should just sort of drift into the liver.
So when do we call it hypertension?
We officially define portal hypertension when that portal venous pressure goes above 12 mmHg.
Wait, hold on. Normal is up to 10 and hypertension is over 12. That seems like a really, really narrow margin of error. Just 2 points.
It is an incredibly narrow margin, and that's why the body is so sensitive to changes here. There's another metric the source mentions, which is the portal systemic gradient. That's the difference in pressure between the portal vein, the intake, and the systemic veins, specifically the inferior vena cava, which is the output.
So the difference between the pressure coming in and the pressure going out.
Exactly. If that gradient, that difference, is greater than 5 mmHg, technically you have hypertension. But the number you really need to lock into your memory, the number that really matters for the patient's safety, is 12.
Why 12? Is that just an arbitrary cutoff?
Not at all. It's based on physics. 12 mmHg is the tipping point.
The tipping point.
The source material calls this the threshold where varices, which are these dilated ballooning veins, begin to develop. Think of 12 mmHg as the structural limit of those pipes.
So below 12, the veins can handle it.
Right. They can handle the load. Above that, the walls of the veins start to weaken and stretch.
So at 12 is the danger zone. That's when the pipes can't handle the load anymore and they start to, bubble out?
They start to bubble out. That's a great way to put it. If you're a student listening to this, 12 mmHg is the number you write down. Below 12, you're monitoring. Above 12, you're in the danger zone for a rupture.
Okay, so we understand the pressure, but why does it rise in the first place? In a house, pipes burst because they freeze or get clogged. What causes the pressure to jump from a nice, lazy 5 up to a dangerous 12?
It all comes down to one word: resistance.
Resistance.
The fundamental problem in portal hypertension is an increased resistance to blood flow. Imagine you have a garden hose and you turn the water on full blast.
Okay.
If the hose is clear, water flows out the end. The pressure inside the hose is relatively low.
Yeah.
But if you step on the hose...
The water backs up.
Yep.
Instantly, it stops flowing out the end, and the section of the hose right behind my foot gets hard and swollen. The pressure just skyrockets.
Exactly. In this analogy, the liver is your foot. The liver acts as the bottleneck. In the vast, vast majority of cases, the liver itself has become stiff or scarred or just architecturally distorted.
So the blood can't get through.
It tries to enter the liver sinusoids, these microscopic channels inside the organ, to get filtered, but it just hits a wall of resistance. It can't flow through easily, so it backs up into the portal vein, and the pressure rises.
Okay, that makes perfect sense. The liver is the bottleneck. But the source material breaks this down even further. It talks about a classification system: prehepatic, hepatic, and posthepatic.
Yes.
This sounds like we're mapping out exactly where the traffic jam is located.
That's a great way to visualize it. And this classification is vital for diagnosis because it tells you the root cause. If you don't know where the block is, you can't fix it.
Okay, so let's start with prehepatic.
Prehepatic. This is a blockage that happens before the blood even gets to the liver.
So using our traffic analogy, the road is blocked before you even reach the city limits.
Correct. The liver itself might be perfectly healthy, it's working just fine, but the pipe leading to it is clogged.
And what would clog it?
The most common cause here is a portal vein thrombosis. That's a blood clot just sitting right in the main portal vein.
How does a clot just form there?
Well, it can happen for a few reasons. Maybe there was an infection in the abdomen, like a bad case of appendicitis, that caused inflammation and clotting. Or maybe the patient has a genetic blood disorder that makes them clot too easily. Sometimes it happens after a surgery.
But the result is the same.
The result's the same. The intake pipe is plugged.
Okay, so that's prehepatic. Then we have hepatic, which is inside the liver. I'm guessing this is the most common one.
By far, this is the big culprit. The source emphasizes this over and over. Cirrhosis of the liver is the #1 cause of portal hypertension worldwide.
Cirrhosis. We hear that word a lot. People usually associate it with alcohol, but it's really just a description of what the liver looks like, right?
Yes, exactly. Cirrhosis is the end stage of any chronic liver damage, whether it's from alcoholic liver disease, chronic hepatitis B or C, or non-alcoholic fatty liver disease. The end result is the same mechanism. The soft, spongy tissue of the liver gets injured over and over. The body tries to heal it, but instead of regenerating healthy tissue, it just lays down scar tissue, fibrosis.
So the liver turns from a sponge into a brick.
That's a vivid image, and it's very accurate. The microscopic architecture is just destroyed. The tiny blood vessels inside the liver get squeezed shut by these bands of scar tissue, and that creates massive, massive resistance. It's the ultimate bottleneck.
Okay. And then finally, we have posthepatic.
Yeah.
This is a blockage after the liver. So the blood has made it through the factory, but it can't leave to get back to the heart.
Right.
This one surprises me a bit. How does blockage after the liver cause pressure to build up before it?
Think about a river. If you build a dam downstream, what happens?
The water level rises upstream.
It rises upstream. In the body, blood leaves the liver through the hepatic veins to go to the heart. If those veins are blocked, a condition called Budd-Chiari syndrome, or if the heart itself is failing.
The blood can't exit.
Specifically, right heart failure. If the right side of the heart is too weak to pump blood forward, that blood backs up into the inferior vena cava, then it backs up into the hepatic veins, it congests the liver, and eventually it raises the pressure all the way back in the portal vein.
That is fascinating. So a heart problem can actually show up as a liver pressure problem.
Absolutely. Something like constrictive pericarditis, where the sac around the heart is too tight, or right heart failure can back up pressure all the way down the line. It just highlights how interconnected the entire vascular system is.
You really can't look at the liver in isolation.
Never. You have to look at the pump, which is the heart, and all the pipes, the veins, as one continuous circuit.
Okay, so we have a blockage, usually cirrhosis, and the pressure is building up behind the liver. The blood has nowhere to go. But the body is resilient, right? It doesn't just give up.
No, it tries to fix the problem.
The source material talks about Portosystemic Collaterals. What are these?
This is one of the most remarkable and yet dangerous adaptations of the human body. When the main highway, the portal vein through the liver, is blocked, the body instinctively tries to open up old, unused backroads.
Oh.
It forces blood into these tiny dormant veins to bypass the liver and get the blood back to the heart. These bypass routes are called Portosystemic Collaterals.
Nature finds a way. It's creating a detour.
It is, but there's a major design flaw here.
What's that?
These back roads are meant for, local traffic, not highway traffic. They are small, thin-walled veins, and suddenly you are diverting a massive volume of high-pressure blood into them. They just aren't built for it.
So they stretch.
They stretch, they bulge, and they become incredibly fragile.
And these are the varices we talked about earlier.
Exactly. And the source identifies a few critical danger zones where these collaterals tend to form. The most dangerous one, the one that keeps doctors up at night, is in the gastroesophageal region.
Why is that the most dangerous?
It's all about location and how thin the lining is there. These become esophageal varices. Imagine a vein just bulging into your throat, stretched as thin as a balloon that's about to pop.
And it's right there where you're swallowing food.
Exactly. You're swallowing food past it. There's stomach acid refluxing up near it. It is a very hostile environment. If that varic bursts.
Massive bleeding.
Massive bleeding into the GI tract. It is the single most lethal complication of this whole condition.
The source also mentioned something called caput medusae. That sounds incredibly mythological.
It is visually striking. These are collaterals that form around the belly button, the paraumbilical veins. When they dilate, they radiate outward from the navel like snakes on Medusa's head.
Wow.
It's a classic clinical sign that just screams there is a major blockage inside.
And there are others too, right? Like rectal varices.
Yes, anorectal varices. They're sometimes confused with hemorrhoids, but the underlying cause is obviously much more serious. We also see retroperitoneal collaterals, which are deep inside the abdomen, but clinically it's the esophageal ones that kill.
So we have these hidden time bombs. But how does a patient actually know they have this? Do they feel the pressure?
That's the tricky part. Patients very rarely complain of pressure in their abdomen, not in the way you'd feel a headache. They present with the complications.
I see.
The diagnosis often starts with physical signs the doctor finds, like splenomegaly, an enlarged spleen, or ascites, which is fluid buildup in the belly.
And the source gives us a golden rule for diagnosis. It says, upper GI bleeding in a cirrhotic patient is varices until proven otherwise.
That axiom is burned into the brain of every emergency physician and every medical student.
Why is it so important?
Because if a patient with known liver disease comes in vomiting blood, you don't waste time assuming it's an ulcer or a tear. You assume it is a burst varix, because that is the thing that will kill them the fastest. You have to assume the worst to save the patient.
Let's talk about that exact scenario. We're moving into code red territory now. The pipe has burst. The patient is bleeding. What does that look like?
It's a terrifying scene. We're talking about massive hematemesis that's vomiting bright red blood, or melena black tarry stools, which is digested blood passing through the system.
And they can go into shock.
Very quickly, the volume of blood loss is so rapid, their heart rate spikes, their blood pressure absolutely crashes.
The source outlines a very specific protocol here, an order of operations.
Yeah.
And I think this is where that exam mindset really helps, because in an emergency, you need a checklist. What is step one?
Step one is always airway protection.
Airway first.
It doesn't matter how much blood they're losing if they can't breathe. Because these patients are often actively vomiting blood, the risk of aspiration of choking on that blood is huge. If they inhale blood into their lungs, they can drown.
So you secure the airway.
Often by intubating them immediately.
Okay, airway is secure. What's next on the list?
Step two is fluid resuscitation. You have to replace the volume they've lost to keep the heart pumping and maintain blood pressure.
And step three is blood transfusion.
Right. You need to replace the red blood cells so the remaining blood can actually carry oxygen. But there's a nuance here.
What's that?
You don't want to overfill them.
How can you overfill them if they're bleeding out?
Well, if you pump too much fluid back in too fast, you raise the pressure in the veins again, and you might just pop the clot that's trying to form or start a new bleed. It's a very delicate balance of giving just enough to keep them alive, but not so much that you restart the whole problem.
That makes sense. And then we still have a bleeding vein to deal with.
Right. Step four is endoscopic control. This is the definitive fix.
You go in with a camera.
You go in with an endoscope, find the exact bleeding vessel, and stop it.
How do you stop it? It's all internal.
We have a couple of very effective tools. The gold standard is something called endoscopic band ligation.
Band ligation.
Think of it like a tiny rubber band gun on the end of the scope. The doctor sucks the bleeding vein into the tip of the scope and then snaps a tight little rubber band around the base.
Wow.
It cuts off the blood flow instantly, just like tying off a balloon.
That is incredible technology. And what's the other option?
The other is sclerotherapy. That involves injecting a chemical agent directly into the vein that causes it to clot up and shrink down. But banding is generally preferred these days. It's very effective.
Now here is where the source warns us about an exam trap. My first thought, and I imagine a lot of people's first thought, is internal bleeding. Let's go to surgery. Open them up.
And that is exactly the wrong answer on an exam, and usually in real life too.
Why?
The source is very clear. Surgery is not first-line therapy for an acute variceal bleed. A cirrhotic patient is often in very poor health. Their blood doesn't clot well. Their liver is failing. A major open surgery carries a massive mortality risk.
So you stay minimally invasive.
As much as possible. Endoscopy is the hero here.
Okay, so we've handled the acute crisis. But let's step back a bit. Most patients aren't bleeding out every single day. They're living with this condition. So what does chronic portal hypertension look like? The outline mentions ascites.
Ascites. This is actually the most common complication of portal hypertension.
And what is it exactly?
It's the accumulation of fluid within the peritoneal cavity, in the abdomen. Patients will notice their belly just getting bigger and bigger, feeling tight and full, even if they're losing weight everywhere else.
Why does the fluid leak out? Is it just the pressure pushing it out of the veins?
That's half of the story. It's a double hit. First, yes, the hydrostatic pressure in the portal vein literally pushes fluid out of the vessels.
And the second hit?
The second is that the liver is failing, so it stops producing a protein called albumin.
Albumin?
Albumin acts like a sponge to keep fluid inside your blood vessels. When your albumin level drops, we call that hypoalbuminemia, the fluid leaks out even easier.
So you have high pressure pushing fluid out and nothing holding it in.
Exactly. It's a perfect storm for fluid accumulation.
And how do you manage that?
The management is a hierarchy. It starts simply. Salt restriction. Salt holds onto water, so we cut the salt. If that doesn't work, we use diuretics water pills to help the kidneys flush out the excess fluid.
And if the belly is just too full and tight?
Then we perform a paracentesis. We literally stick a needle into the abdomen and drain the fluid off. It can be liters and liters of fluid at a time.
Does that fix it?
It provides immediate relief, but unless you fix the underlying pressure problem, the fluid will always come back.
The other chronic issue mentioned is hypersplenism. The spleen gets involved. Why is the spleen acting up?
Remember our plumbing map? The splenic vein drains directly into the portal vein.
Right.
So if the portal vein is backed up, the splenic vein backs up too. The spleen becomes engorged with all this trapped blood that's splenomegaly. It gets big.
And when the spleen gets big, does it stop working?
Ironically, it starts working too hard. The spleen's job is to filter old blood cells out of circulation. When it gets enlarged and congested, it goes into overdrive. We call that hypersplenism.
So it starts destroying cells it shouldn't be.
Exactly. It starts destroying healthy blood cells much too aggressively.
And that leads to?
That leads to anemia from low red blood cells, leukopenia from low white blood cells, and most importantly for our listeners to note, thrombocytopenia.
Low platelets.
Very low platelets. And platelets are what you need to form a clot and stop bleeding.
Oh, wow.
So you have a patient who is already prone to catastrophic bleeding because of their varices, and now their own spleen is destroying the very cells they need to stop that bleeding. It's a vicious, vicious cycle.
Is that a late sign?
Actually, and this is a key insight from the source, thrombocytopenia is often the earliest lab abnormality we see in these patients. Before the ascites is obvious, before they ever have a bleed, you might just see their platelet count start to drop on routine blood work. That is your early waning sign.
That is a crucial nugget for anyone looking at blood work. So how do we confirm all of this? If I suspect portal hypertension, what tests am I ordering?
Well, you need to visualize the flow and see the consequences. An ultrasound with Doppler is great because it's non-invasive and can actually show you the direction and speed of blood flow in the portal vein.
Okay.
You'll check liver function tests, LFTs, to see how the factory is running. But there is one test that the expert marks as absolutely mandatory. Endoscopy. Every single patient diagnosed with cirrhosis or even suspected of having portal hypertension must have an endoscopy.
Why?
You have to go in and look for those varices. You cannot wait for them to bleed to find out they're there. You need to know if they exist so you can start preventative treatment, like medications, to lower the pressure.
Okay, so we've diagnosed it, we're managing the fluids, we're watching the spleen. But sometimes medications and rubber bands just aren't enough. The pressure is just too high. Is there a bigger fix? The outline mentions something called TPS.
Yes. When medical management fails, we move to interventional radiology. And TPS stands for Transjugular Intrahepatic Portosystemic Shunt.
That is a mouthful. What does it actually do?
It sounds incredibly complex, but the concept is really elegant. Remember how the liver is the bottleneck?
Right, the brick wall.
TPS essentially creates an artificial tunnel, a shunt, right through the liver. The doctor goes in through a vein in the neck, that's the transjugular part, navigates a catheter down to the liver, and places a stent that connects the high-pressure portal vein directly to the low-pressure hepatic vein.
So it's a bypass road built right through the middle of the traffic jam.
That's exactly what it is. It lets the blood flow straight through, bypassing the resistance of all that scarred liver tissue. It lowers the portal pressure almost immediately, and it's much preferred over the old-school open surgical shunts because it's so much less invasive.
It sounds perfect. Why don't we just do this for everyone with the condition?
Because there is a very significant trade-off, a major downside.
Now, what is that?
This brings us back to the liver's whole purpose. The liver is a filter, right?
Right. It cleans the blood.
It cleans toxins, like ammonia, out of the blood before that blood goes to the rest of the body, especially the brain. So if you build a tunnel that bypasses all the filtering liver tissue...
Bypassing the filter.
You're bypassing the filter. The dirty, unfiltered blood goes straight into the systemic circulation, and it reaches the brain. This creates a very high risk of a condition called hepatic encephalopathy.
What's that?
The toxins build up and affect the brain. It causes confusion, disorientation, personality changes, and in severe cases, even a coma. So TPS is brilliant for fixing the pressure, the bleeding, and the ascites, but it comes with this major risk to brain function. It's a delicate balance.
That is a heavy, heavy trade-off. It really highlights that there are no perfect solutions when the system is this compromised.
And one final surgical nuance the source mentions: splenectomy. You might think, okay, the spleen is big and it's eating all the platelets, let's just take it out.
It seems logical.
But it's generally avoided in this situation. Removing the spleen in a patient with portal hypertension carries a huge risk of causing a clot to form in the portal vein, a thrombosis after the surgery, which would just make the pressure even worse.
So you can make the whole problem worse.
You can make it much worse. So despite the splenomegaly, we usually leave the spleen alone.
Wow. It really is a game of 3D chess. You fix one thing, you risk breaking something else entirely.
That is the essence of managing complex physiology.
Well, we have covered a massive amount of ground, from plumbing physics to emergency protocols. Before we wrap up, let's do a rapid-fire recap. The top 10 key takeaways from this deep dive.
Let's do it.
I'll tee him up, you knock him down. Number 1, the danger number.
Portal pressure greater than 12 millimole Hg. That's the threshold for varices.
Number 2, the main culprit.
Cirrhosis. It is the #1 cause of portal hypertension, hands down.
Number 3, the geography of the blockage.
Remember the classification. Prehepatic, like clots, intrahepatic, which is cirrhosis, and posthepatic, like heart failure.
Number 4, the physical sign to watch for.
Splenomegaly. An enlarged spleen is a classic hallmark of this condition.
Number 5, the immediate threat to life.
Variceal bleeding. It is sudden, massive, and it's lethal if it's not treated right away.
Number 6, the first line of defense for that bleeding.
Endoscopy. Specifically, band ligation is the gold standard.
Number 7, the trap to avoid.
Surgery is not the first move for an acute bleed. Do not open them up unless you absolutely have to.
Number 8, the most common complication.
Ascites. Fluid in the belly. Manage it with salt restriction and diuretics first.
Number 9, the early warning sign you might see in the lab work.
Thrombocytopenia. Low platelets. It often shows up before anything else.
And number 10, the modern fix for when all else fails.
TPS. The transjugular shunt. It's great for the pressure, but you have to watch out for encephalopathy.
Fantastic summary. As we close out, is there one final thought you want to leave our listeners with? Something for them to mull over.
I think what fascinates me most about portal hypertension is what it reveals about the body's priorities. You know, when the liver is blocked, the body doesn't just stop. It creates those collaterals. It builds those dangerous bypass roads. It prioritizes flow, just keeping the blood moving at all costs over structural integrity. It would rather risk a burst vein than let the entire circulation grind to a halt. It's this incredible miracle of adaptation, but it's also a ticking time bomb. It just reminds us that the body is always, always fighting for immediate survival, even if its solutions are imperfect and dangerous.
Survival at any cost. That is a powerful way to look at it. Thank you for guiding us through the pressure cooker today.
My pleasure.
And to you, the listener, thanks for diving deep with us. If you enjoyed this breakdown, make sure to subscribe and share it with anyone who loves to understand how things work. And remember, whether you're taking an exam or just navigating life, exams test clinical thinking, not just isolated facts. We'll see you next time.